information dissemination. Any other insights from the audience or questions, please? If you could raise your hands earlier, make sure someone gets you a mic. There you go. Go ahead.
Good afternoon, everybody. It's working. Yeah, good afternoon, everybody. My name is DM Sharma. As we look at different levels of accreditations in healthcare industry, do we have any accreditation body for this information data and its processes in international governing bodies? Do we have anything?
I think that's one of the things that we have to that. Right now, when we're visualizing the area where devices will become literally ubiquitous across the country and across the world, Qualcomm is taking the lead in creating some type of a methodology called UNet, 2Net, where you can register your devices. So different things are happening across. Our actual goal or hope is that WHO takes a role in becoming a unified body. So WHO has a subgroup in health informatics, which is now leading into this. The power of the ICD-10 coding happened because of the universal acceptance came because of WHO. So I think WHO is being pushed. The last Geneva meeting had that kind of focus or impetus that informatics bodies across the world and governments across the world would put the onus of universalization of standards or methodologies for information exchange, because certain standards have existed for many years and we don't expect people to change. But mapping one standard to another so that there is universal portability of data and information, WHO will be taking the lead. Anyone wants to add to that?
Yeah, just to add, from a European perspective, your question is becoming increasingly pertinent. There's a big move, some people, colleagues from Europe in the audience may be familiar with this. There's a big move towards attempting standardization around different aspects of patient mobility and professional mobility in Europe. The European law is such that employees from a European country have the right to work in any other European country. And similarly, what Europe are pushing is that there should be equity in the basket of care that's provided for any patient within Europe. And if the country in which you're residing is unable to provide that care within an appropriate time period, and therefore there's an undue, and I'm carefully using inverted commas here because this is the terminology, an undue delay in their care, then there is an entitlement to go to another country. So with that pushes the whole clinical governance aspect of standardization in healthcare standards, standardization in how we use information technology to not only provide a seamless continuity of information in relation to the patient, but where I'm most concerned is information in relation to the professional who rolls around a different few countries from time to time, so that when there are adverse events, they've already moved on before they're captured. And there are a number of people like that. So I think that's probably also what's pushing the WHO into getting more involved around this space, because some of the regions internationally are stepping very strongly into that, and you can't step into it without considering the whole technical standardization around information technology.
Perfect. I think that was very important as we seek to see that the information about healthcare moves seamlessly from primary to secondary to tertiary care. As that data is captured in a manner that can immediately be available in the point of care at the right time in the right place, the next level of moving that information to assist in research and also to assist in education is really important and significant, and standards are necessary for it. But thank you for those observations, Tracy. Dr. Anupam Sibal has the mic, and immediately, Anupam, 1 second please. Mark had one thing to add.
Yes, just quickly on that, and we're here in India, and we've been talking a lot about the issues within India, and I'm a bit of a skeptic. I think if we try to do this universally around the world, globally, I think you may miss an opportunity, because it takes a long time. I constantly challenge the team that works with me around, and they're doing a lot nationally and internationally around standards, but I make the analogy, are we trying to get the whole world to speak English? and that's never really worked. I think you have an opportunity within your country to set standards, and the banner out there that we all get to sign is a step toward that. But if you really wait for HL7 or WHO or whoever to define the standards that need to be put in place, I think it could be longer than you're willing to wait to get some of the benefit out of the standards and the technology.
Every moderator loves controversy. So now we have one end of the podium saying that here we need universal standards.
We need them. We need them.
Yeah.
I don't know. I'd wait for them, though.
No, but I think what Mark said was an important point, just so that we don't miss it, that you start at one place and don't wait. And somebody said that, we're not building the Sistine Chapel. When you're using IT, you cannot wait 17 years for that Sistine Chapel to be painted. In IT, you can continue to move. Get some ground, cover it, implement, change once again. That's the momentum and the dynamism capable in IT. So let's figure out ways to work together, keep moving, keep improving. We got you, Mark. Thank you. Anupam.
This has been an absolutely fascinating panel discussion, and thank you all the panelists for enlightening us with your wisdom. To actually build a culture of patient safety, what you really need is the right mindset. You have to have the leadership, and everyone in the organization feel very strongly about it, and actually have this atmosphere where people realize that they need to learn from each other and learn from other organizations. And I just want to make this point that a lot of people believe that only big hospitals can actually embrace patient safety, or they can make their facilities really patient safe. And that's really not true. When we first started on our journey of Apollo Clinical Excellence, and patient safety is an important component of the Apollo Clinical Excellence model, we started with our JCI accredited hospitals. We started with Chennai, Hyderabad, Bangalore, Delhi, Calcutta. And then we went to the NABH accredited hospitals. And then we said, well, it can be done in every hospital. And we chose Aragonda. Aragonda is a very special place for us. That's where Dr. Reddy was born. It's a small village that has huge challenges with basic stuff like water. And today, Aragonda is an example where it scores really well on the Apollo Clinical Excellence model. And that's because everybody in the team there believes that patients come first. Patient safety is really very, very important. So what we will during the course of the next day or so, as we have stakeholders from across the country, from big hospitals to nursing homes to clinics, on the lines of the Cyberabad Declaration, we will have the Hyderabad Declaration, which is on patient safety. And I think all of you at 3M and Johnson & Johnson and BD and every other company that has a product would really welcome this, because we are putting together this charter on how we're going to make patient safety really important. Talk about creating patient safety teams in all facilities, and how is it that we can make this as a part of the curriculum in medical education, and also part of the training for everyone in the healthcare domain across hospitals, clinics, nursing homes.
Sangeeta,
Yes.
I have a question, and while we're waiting for the Chief Minister, before you're going to get your panel to start singing and dancing while we're waiting for them, let me ask a question. Most of the questions here were focused on a patient in terms of being within a hospital or a healthcare facility. But broadly, a patient doesn't necessarily have to be that. So I'd like this panel to say how much of your focus is for the real patient, people who are diagnosed or who will in future be diagnosed with an illness. What's the focus I know in IT there are lots of interventions, but what's the focus on safety for them? Is anything being done in that space?
Would like to take.
I think that's a very interesting question, which is you're talking of the patient before he comes into the healthcare facility, right? Now, I can only relate to it from one angle and one prism, which is relevant for BD. And one of the issues that we are really talking about is patient safety from unsafe injections. You'd be surprised to know, many people in this room, that 7 billion injections are given in the country from only 3.5 billion syringes. Which means, on an average, every syringe, though it's supposed to be a disposable plastic syringe, is reused at least twice. The unfortunate part is that it's so difficult to reach out, because 65% of injections are given in the outpatient setting, in the GP clinic or even in smaller places all across the country. And that's to do with information, knowledge, skill. So we have developed technologies for the immunization sector and for the curative sector of an auto-disabled syringe, But that is not enough, because fundamentally it's a behavior change and information both to the patient community and to the doctors who are using it unwittingly from one patient to another. The other aspect of that issue is the fact that after they throw it out, it gets recycled back by unscrupulous people who may repack it. And that's where the patient safety element of patient awareness, as well as the clinician's awareness on how to dispose it after it has been disabled. So that's one angle which is there. Related to irrational use of injections is a very strong issue of irrational use of antibiotics. Now, we as a company have nothing to do with antibiotics, but somewhere it connects with the irrational use of injection. And that's again to do with dissemination of information and your earlier point about using mobile phones. So you've developed a little video clip which shows how the device works. It eliminates the need for face-to-face training, and it can be sent from one mobile phone to another mobile phone. So that's a very small sliver of that whole big issue that we can contribute in.
Excuse me, ma'am. Yeah, if I can just add to what Rajneesh says, I want to give you two examples. One example of a product which exists today in the country. It's a simple product which prevents patients from getting bed sores. You know, it's a film and it is applied on patients. So what happens is you are preventing complications in a patient, especially when you have long-term stay in a hospital. So those kind of products exist, which is related to patient safety. The other example I wanted to give you is from the DRG space, the groupers we have, which is diagnosis related groupers, which has so much clinical data, and it is used for decision making at the macro level, at the government level, to predict what will be the the disease levels and where the